Let's get started. Okay, so let's talk all about digestion. So, for the next half an hour or so, you're going to find out about digestion. We're going to talk a little bit about two very common conditions, IBS and reflux, but a lot of this will actually be more about bloating, the mechanisms behind why people have chronic digestive issues. Talking about, how these things start, the risk factors. Interestingly, a lot of times for a lot of people, we can start seeing things happen in childhood that manifest in adulthood. And by the end, hopefully, you'll have a clear understanding of what common digestive symptoms like bloating, reflux, and IBS can mean, and the different factors that contribute to them, and then also a stronger foundation in how digestion works. There we go. Okay, a little bit about me. Digestion is really my bread and butter. I have, a few focus areas, but I do see a lot of digestion in clinical practice. I myself have a chronic digestive condition, and so that's one of the reasons why I decided to really focus in this area. I've presented to over 1,000 healthcare practitioners on digestive health across Canada and the States. And so I've really seen this from both sides, clinically and personally. So my focus is really to help patients understand their unique patterns of symptoms and building really a clear, more structured plan to actually move things forward as it relates to their digestive health. And really quick before we dive in, here's my process. And this has to do with, any health concern that anybody has when they come to see me in clinical practice. So I want to investigate, I want to identify, and then I want to implement. So, for example, in digestive issues, we're looking at, the microbiome that's shifted, how the brain communicates to the gut, whether there's levels of systemic inflammation that we're seeing. I use a lot of lab testing in my practice, which usually is just basic blood work that I send to get done at Life Labs. We're really looking at like root cause investigation. What I mean by that is like, what is the diagnosis? What is the cause? So rather than somebody saying, oh, I have leaky gut, we actually want to figure out what caused that to begin with. We discuss a lot of personalized strategies. And one of the big goals and lots of conversations I have with my patients is removing obstacles and implementing practical habits because a lot of the time people will come to me and they actually know what to do. They know that, for example, they want to be eating breakfast more often or they want to have more structured meals, but it's actually about implementing a strategy to do that. And real quick, so we've done this is the second community medicine free webinar that we've got planned, but the next one's going to be on perimenopause in May, and then we're jumping back to digestion, constipation as the topic in June. So save the dates there. And if you miss the slide or don't end up writing it down, you'll get the recording so you can reference this again. Just a quick FYI, everything in here is for educational purposes. We're not talking about specific medical advice. So it's not intended to treat or diagnose. Let's talk about like, digestion from the mouth to the anus. So it is a coordinated step-by-step process where each part interestingly affects the next. So normal digestion starts in the mouth, then it moves to this, well, through the esophagus to the stomach, to the small intestine, and to the large intestine or the colon. And so when we have symptoms, they often reflect where something is off in this sequence. And so let's talk a little bit more about each section there. So digestion really starts in the mouth. It begins before you even swallow. So when we chew, we have enzymes in our mouth that mechanically break down our food. And we also have saliva. So this contains, like I said, enzymes. We start digesting carbohydrates. We want to think about whether we're eating quickly or not chewing well enough. And so this could be like something very, very straightforward is that if we're eating and we are, let's say, dealing with like urgent emails, is we may not be chewing enough. And we'll talk a little bit more about how many times we should be chewing. Not chewing enough may impact everything downstream. And then we go through the esophagus to the stomach. And so this is really where like our stomach acid shines. And this is where we break down food. And so the stomach uses acid and enzymes to break down proteins as well as killing pathogens. That's an important factor here because some people who have lower stomach acid levels may be at increased risk of certain infections, like such as when we're on a proton pump inhibitor, which is the main drug class for GERD, acid reflux, is over time that person is actually at an increased risk of C. difficile, which is a really nasty infection. In the stomach, food is turned into semi-liquid mixture before moving on. And this is also where those satiety signals or those like that satisfaction signal starts. And then we move into the intestines, which, for our purposes, we've got the small intestine and the large intestine. Large intestine is also known as the colon. And in the small intestine, this is where the majority of digestion and absorption happens. And that's key. This is our absorptive surface for the most part. So we have enzymes from the pancreas and bile from the gallbladder. So you've got the pancreas, the gallbladder, and the liver all like supporting the small intestine here. And we see the breakdown of fats, carbs, and proteins. But we also see the absorption, like I said, of nutrients. So we've got vitamins, minerals, amino acids, fats. Those are all absorbed and transported in the bloodstream. And then the last part is the colon, or the large intestine. This is where the overwhelming majority of our microbiome, which is the collection of all the organisms, this is where the microbiome is mostly located. Although we also have some bacteria in much smaller amounts in our small intestine, we have some even like on our skin and in the vagina as well. But it's mostly in the large intestine. So we see gut bacteria ferment food particles, and that's going to produce gas as well as short chain fatty acids. Short chain fatty acids, important. Those are like these metabolites that are really protective. They go on to do other really important things in our gut. And we'll see later that what we eat, especially the types of fiber, are going to influence that production of these metabolites. So the take home of this slide, and in discussing why digestive symptoms happen, is that there isn't just one cause. And it's important to know that symptoms are signals and they're not random. So digestive symptoms can happen for a number of reasons, and this really simplifies it into some categories. We've got, motility issues where things may be moving too fast or too slow. So we can see diarrhea, constipation, a mixed pattern too. We can see a sensitivity mechanism, which is where the gut and the brain maybe are like miswired, we'll call it. Very common in patients that have irritable bowel syndrome. We can see it due to neurological issues. So, for example, patients that have Parkinson's, which is known to be a neurological condition, we will see issues with motility. So, the way the brain, again, is communicating to the gut is able to affect the digestive system. Another mechanism is fermentation. So, how food is fermented, we're going to see in that case often higher levels of bloating and gas. Somebody can have an issue with stomach acid as well as reflux mechanisms. There are definitely hormonal influences. It's not uncommon for me to see patients in their perimenopause years and all of a sudden their digestion is worse. And similarly, for women or people who are cycling, is the week before someone's period, we may be more likely to see both constipation and diarrhea. So there's a progesterone aspect to some people's digestion. And then as well as inflammation. So like microinflammation at the gut wall, as well as frank inflammation or systemic inflammation that we can see in conditions like inflammatory bowel disease, which is Crohn's and colitis. And so this maybe looks a little bit more like a technical slide. I don't usually do this level of technicality in a free webinar, but this is actually really important because we can see so many different causes of digestive issues. And as my job as a practitioner, I'm trying to see, is it an issue of physiology or abnormal physiology? Is it an issue of perception, which is the way we have like basically signals amplified to the brain where we're feeling pain, for example, in our digestive system after drinking water, but the next person beside us has no issues? Or is it an issue of infection? And often it can be due to all three. which makes things a little bit tricky, right? So, for physiology or abnormal physiology, we're looking at conditions like celiac disease, which is an autoimmune condition where the body actually attacks your small intestine in the presence of gluten. And then we can see major digestive issues, also nutrient absorption issues. Issues of physiology are also Crohn's colitis. Microscopic colitis is also a type of inflammatory bowel disease. And this is where we have significant levels of inflammation causing tissue destruction or tissue issues along the gut. And as well as some types of GERD, which is your gastroesophageal reflux disease. Particularly, there's two types here that are known to be abnormal physiology. There's erosive esophagitis and non-erosive reflux disease. We'll talk more about that. But then on the flip side, issues of perception. And again, this doesn't mean that it's all in your head. It's more about how we're feeling our gut and the communication and how that manifests in digestive issues. So issues like irritable bowel syndrome. There, interestingly, are some types of reflux that are more of an issue of perception rather than an issue really of acid itself. And then there are many disorders of gut-brain interaction. There's actually more than 30 conditions that fall under this category. But what's important to me, especially when I see people where they're saying, let's say there's chronic bloating or there's chronic reflux or chronic pain, is we want to look at, is there an infection happening? Like, for example, H. pylori, very common infection in the stomach. Is there small intestinal bacterial overgrowth happening? Sometimes people will have candida overgrowth. And sometimes, but not always, infections can actually lead to issues of perception. So if people on this call, some of you may have been around long enough for when the Walkerton crisis happened in Ontario in the early 2000s, which is where there was contamination of their water supply with really harmful E. coli. About 40% of that population went on to develop IBS compared to about 10% of the normal population. And that's because there was an infection that led to it. And so you may have read about the term leaky gut, which is not actually a medical term, but what it does refer to is something called intestinal hyperpermeability. And this is like it basically references like our gut like a coffee filter, for example. So what our small intestine is supposed to do is supposed to act like a very well-fitted coffee filter, not allowing large grains of coffee to come through. It's only allowing the good stuff that we want. So with leaky gut, though, we're talking about like a barrier dysfunction. And so this is where we end up getting, like, for example, some bacteria, some macromolecules, proteins that we don't want, toxins end up coming through, and then we get an immune system response. And so, truly, with leaky gut, we actually see it in very specific conditions. We can see it in inflammatory bowel disease. We can see it in celiac disease as well as irritable bowel syndrome. We can see it in small intestinal bacterial overgrowth, as well as in acute gastrointestinal infections. So things like food poisoning, candida overgrowth, etc. And so when we have these like kind of collective non-specific symptoms of leaky gut, we actually really want to figure out what's causing it. And think of this slide like your cheat sheet. So for anybody that has bloating, the internet's going to tell you, oh, it's what you ate, or, oh, you need to take this supplement. When a patient comes to me for bloating, there are many, many potential causes here, and I've actually left out a few. So, for example, in that category of disorders of gut-brain interaction, which I've lectured on to my colleagues a few times now, we have at least 30 conditions even just under that umbrella alone. Um, so with bloating, my job is to like investigate, to save you time, for example, to really figure out like what can we easily rule out here and what do we feel like is maybe happening. And there are some where I will call it basic causes of bloating. Like for example, somebody with a lactose intolerance. That's generally quite straightforward to figure out. We can take out dairy. We can experiment with lactose-free options or the lactase enzyme, which is an extra supplement, and figure out if that resolves somebody's digestive issues. We can also see other carbohydrate intolerances, so things like fructose. The whole FODMAP category. So the FODMAP foods are the fermentable carbohydrates that patients with IBS tend to be sensitive to. But as you can see here, there's a whole bunch of other things. We can have issues with like uncontrolled diabetes causing bloating, real, very specific motility issues, female hormone causes such as fibroids, endometriosis, even swallowing air. And again, that's more, I will say, an easy one because we can try to figure out why somebody is swallowing air and come up with a plan there. Some medications, surgeries, fluid in the abdominal cavity. Interestingly, pelvic floor dysfunction and diaphragm dysfunction can definitely lead to bloating. Thyroid is an independent driver of digestive issues. Pancreatic insufficiency, intestinal pseudoobstruction, mechanical obstruction, malignancy. So think of this kind of like there's definitely other ones, but these are really the main drivers of bloating, and we want to know which one is it or which ones because it's somewhat common to have multiple. What's important on this next slide here is bloating versus distension. So they're they actually mean two different things. And often when I'm talking with patients in practice, when they say bloating, they mean distension. We can actually have both at the same time. So with bloating, that's more of a subjective feeling. Kind of like I feel like there's a balloon in my abdomen. I feel this discomfort is often the word described, or like a pressing out feeling. But distension is where we actually see an increase in the girth, like the circumference. And there are six, we call them six F's to abdominal distension. So fat, fluid, such as in like ascites. So we actually have a fluid accumulation happening. Feces, so somebody who's very constipated will actually see an increase in the girth. Excess gas or changes to how gas is distributed, we'll see an increase in that circumference. If somebody is pregnant, so fetus, and then something called fatal tumor or flippin big mass is what they call it, which can be a large solid mass such as an ovarian tumor, even uterine fibroids, which is actually quite common as like a mass that's a benign mass in women, or other abdominal malignancies. And so tracking, like for people, a conversation that I have often is tracking. Is this bloating? Is it distension? Is it happening at the same time? What's it happening with? What time of day? Is it after food? Does it matter? Those are important pieces of information. And I also want to talk about some pretty common digestive myths. And I took this from TikTok and the internet and Instagram and such, but bloating is not always, so the myth being bloating is always food related, but bloating is not always food related. In fact, it's a conversation that I have often where somebody says, I got bloated one day with this food and I had it the next day and I wasn't bloated at all. And it doesn't make sense. And that's a very common pattern to have because there's other mechanisms, such as how the brain's communicating in the gut, the food environment in which somebody ate. There are other things happening. The myth being reflux is always too much stomach acid. That's not true either. And you'll find out when we talk a little bit more about reflux is it has to do with sometimes too much stomach acid, but sometimes due to how the acid shifts, the volume or the frequency of the reflux that happens. Um, so people without GERD or without reflux actually have 40 episodes of reflux a day. We just don't feel it. So for some people with reflux, it's actually how their brain is perceiving those acid shifts in an inappropriate way. Myth number three here: IBS is just stress. It is so much more than that. Stress can make it worse, but it is not the cause. And then the last point here is healthy eating should fix everything. And that's not always true, right? Especially in issues with an abnormal physiology or where we've seen like irreversible tissue damage in the gut. Healthy eating can probably help, but it is not going to get somebody often back to like 100% where they were before. For some people, healthy eating will fix it. And again, it depends on what's going on. And so, when it comes to somebody's treatment plan, depending on really what's going on, we want to talk about healing, and I put healing in quotations here because for some or for a lot of chronic digestive conditions, they are lifelong and is more about how they're managed. They will ebb and flow. I do find, like there's some resources that really paint a picture that these conditions can be healed, which actually does mischaracterize these conditions. So when we're talking about a treatment plan, these are all the points that I'm thinking about. Is there something called visceral hypersensitivity, which is where the brain is sensing the movement of food really acutely, like much more in a much more sensitive way compared to somebody else who doesn't have a chronic digestive issue. We're looking at whether there's been altered mucosal and immune function, which is what we can often see in irritable bowel syndrome, whether there's a motility disturbance, whether we've seen a shift in gut microbiota, which is your microbiome. Again, a lot of data in chronic digestive issues where we've seen a shift there, where we have an overgrowth of, we'll call it more bad bacteria, and a decrease in what we call good bacteria, which is the lactobacilli, the bifidobacteria. You probably recognize those names because they're added. They're typically added to like all the yogurts in the grocery store. Altered central nervous system processing is a really important one. So I do often see people who have like unexplained abdominal pain. Why am I getting pain after a meal? And so we end up seeing in so those functional digestive issues, which is now more formally known, or the newer name is disorders of gut-brain interaction. But we'll see this pain disinhibition, which is where normally when we have like a stimuli and it's causing pain, the brain picks it up and then it's able to inhibit that pain signal. But for people who, for example, have IBS and very similar conditions, there's this disinhibition happening where we have these like amplified signals saying alarm, alarm, pain, pain in a very inappropriate way. Um, we also want to look at like nervous system dysregulation, right? Like whether, for example, there's high levels of stress, high levels of anxiety. Often that weaves its way through digestive symptoms. What's really important is whether we have frank levels of inflammation, because that changes things, in my opinion, as a practitioner. Like that starts to kind of divide things. If we have a lot of inflammation happening, we need to get that down. Whether there's been tissue atrophy, which we can typically see on a scope, and whether malabsorption is happening. So for some people who've had digestive issues for a while, we can start seeing, whether they have low iron, B12, vitamin D, like signs on their blood work, and very basic blood work, I might add, um, where it's starting to suggest that they're not absorbing their nutrients. All right. I may have to speed through the next few because realized I'm only halfway through and we only have 40 minutes. I will leave a few minutes for questions at the end. Basic digestion 101. This can be also like a cheat sheet. So there are such basic things that we can do, such as like chewing your food, counting 20 times to 30 times in your head, eating in a calm environment. Try not to eat when you've got like a deadline. You're working, through your lunch on a deadline, or you've got, urgent emails coming through. It probably won't help your digestion. The use of bitter foods like dark leafy greens, which is kale, dandelion, like cruciferous vegetables like your broccoli, that category, they're all considered bitters and they tend to help digestion too. Cooked versus warm food. Some people find that that should say cooked food versus cold food. That's an error there. But cooked and warm food tends to be easier to digest than cold and raw, for example. Not eating too late, having a relaxing morning routine, the type of fiber. I'm often having that conversation with patients in practice. Sometimes fermented foods, which are high in probiotics, can help. The tracking aspect is important. And then the body loves regularity, eating regularly at different intervals. Sorry, eating regularly at intervals throughout the day. Basic lab testing 101. These are the things that I look for. And if somebody hasn't had them done, then I'm definitely needing to do them. Inflammatory markers, how the liver is functioning, signs of malabsorption, like I mentioned. Whether somebody has unexplained anemia, this is really important. Sometimes there is such a thing as GI microbleed, which is where we don't actually see blood in the toilet, but there's possibly a smaller tumor that is just releasing low levels of blood. So anytime somebody has unexplained anemia, is that something that I and your family doctor will take seriously? Autoimmune markers, kidney function, thyroid function, all important. And I want to go over this slide real quick here because, I have a conversation often about why did I get a chronic digestive condition? And it's often not that straightforward. We have early life influences. So genetics is a big one, culture, environment, adverse childhood events. There's a lot of research now coming out about that. So emotional trauma, physical trauma in childhood, dysfunctional household can all increase the risk of a chronic digestive condition in adulthood. Interestingly, parental behaviors, psychosocial factors, life stress, personality traits, psychological state, the coping mechanisms, social support. They're all in bi-directional communication with each other. Somebody's like physiology, motility, sensation, immune system, or immune dysfunction, inflammation, their microflora, or their microbiome, the food and their food that they eat, or the diet they have. We'll see that manifest clinically as often a functional digestive disorder, which, we talk about symptoms, the severity, the behaviors around their condition will impact outcomes. And we're talking about outcomes like healthcare use, how many times they see their doctor, um, their daily function, quality of life, healthcare costs. What's really interesting is parental behaviors, especially as it relates to young kids having digestive issues. So there is good research here that like the sociocultural factors and family interactions in childhood can shape later reporting of symptoms. So how we interact with our kids' chronic digestive condition and what we say will impact their healthcare use later and how they think about their healthcare, how they think about their digestive condition. So what I mean is the research shows in a family that is excessively worried or anxious, um, symptoms and illness behavior are amplified, which is very interesting. We could talk more about that, but we don't have time today. And I'm quickly going to go over IBS and reflux here. IBS is now not thought to be, the diagnostic criteria is about pain and discomfort or discomfort, pain or discomfort, pain and discomfort. It can be either or, it can be and. At least 1 day per week in the last 3 months, the person needs to have had it for at least 6 months prior. So there's a chronicity aspect to it. And it's associated with at least two of the following: pain related to having a bowel movement, a change in stool frequency, or a change in stool form. IBS is classified as a disorder of gut-brain interaction. So it's characterized by several things. It's not just about what we ate, it's about the microbiome and our food sensitivities, altered gut motility, this heightened gut-brain response. And it makes us more reactive to stress, diet, and internal signals. And with reflux, this is really important too, because I still find that this is not common knowledge unless your practitioner really focuses on gut health or unless you're seeing a GI specialist. Even some family doctors actually are not totally well versed with these last two phenotypes here. We have the main GERD phenotypes, which is your when there's erosion seen on the scope or when there's not erosion seen on the scope, but it's still a type of GERD. But then we also have what is more of an issue of perception. So it can show up the same way that GERD symptoms do, but it's actually where the brain is communicating to your stomach and to the small and into the esophagus. And that's called reflux hypersensitivity and functional heartburn. And the way that they are distinguished is actually through something called a pH monitoring test, which doesn't get done that often. And we'll have symptoms like heartburn, regurgitation. There's silent reflux that can happen too. So not everybody has that classic heartburn sensation. So we can get like throat clearing and hoarseness, or like a lump in the throat, post-nasal drip. And so when it comes to something really easy to implement, there's a lot more research now behind brain gut therapies, especially diaphragmatic breathing. So there's the diagnostic criteria was actually updated a month ago. It's called the Rome 5 criteria for chronic abdominal bloating. They have said that breathing pattern dysfunction is now part of the pathophysiology. It's no longer like a nice to have, maybe you should breathe. It's like we need to breathe to retrain how the diaphragm is moving so that we can improve chronic abdominal bloating. So this is just like a diagram here that shows somebody how to actually breathe with their diaphragm. And you can also look this up. The information is really straightforward, but we want to be breathing into our belly and not let our chest move. And there's only one side on supplements because there are so many evidence-based supplements that do improve certain outcomes when we discuss like targeted outcomes, like such as improving, the frequency of bowel movements or improving constipation or decreasing diarrhea, etc. But um, what's really important is that we have to work with your physiology. So it's not just about, oh, I should take this supplement because I'm bloated. It's like, well, why am I bloated? Was celiac disease ruled out, right? Like basic things like that. And that's where your practitioner um, is very helpful. And so, just a note on why people feel stuck. There's so much conflicting information online, which I'm sure you have already determined. One of the issues is whether there's actually like mismatched expectations. So like when we have a chronic digestive issue, it's not like, going to the gym once and we get buff all of a sudden. It does take time to unwind. It takes time to figure out what the mechanisms are, working on all of them, understanding if there's obstacles and implementing somebody's plan. Sometimes we need more time for a plan to actually take full effect. Sometimes we need to pivot the plan. Sometimes that's just not working. And that's actually not uncommon in digestive plans because, somebody's digestive symptoms can be totally different than the next person, even though they maybe both diagnosed with IBS. So the summary here that uh, I would like you to take home is when we have digestive symptoms chronically, they are not random. There isn't just one cause or one mechanism. Your concerns are definitely not all in your head. And I will say, like DIYing it through Google searching and even through AI searching, I had to correct AI. I'm doing another presentation, and so far I've had to correct it more than 10 times because it's not always right. I was just using it to kind of rephrase some things. So it's quite interesting. But DIYing symptoms often will cost you money, time, and overwhelm. So something to think about. And I showed this in the last presentation here, but here's the utility or the support that you would be getting from a practitioner if you worked with a gut focused practitioner, discussing medical nuance, your unique physiology, strategy for implementation, and a strategy for habit changes. Okay, we made it. We have 2 minutes and 30 seconds left. So if anybody has questions, please put them in the chat. The recording will stop now at this slide, so nobody will be able to see your questions. Um, but real quick, if you don't have a naturopathic doctor and you're looking for one, or if you have digestive issues, I'm happy to help. You can find me at my website here. We can do a digestive health appointment. I also